I know that you have had some experience with some of the oral GLP-1s, the oral Ozempics, Mounjaro, Wegovys. Tell me your thoughts. How's it been going? And let's hear your experience.
Well, I've started the Foundayo, so that is the oral GLP-1, but it's the molecule form and not a peptide. So that's why it's different than like the Wegovy pill. So I was giving it a chance to see how I would react to it compared, because I have taken an oral Wegovy. It was Rybelsus at the time, and I didn't feel very much with that. So
because it was like not so strong, right?
Not so strong. It wasn't. It seems like
the first real oral GLP
exactly
one, but it really never got any movement. It was way before Ozempic.
Yes. Yeah. It was. Oh God, I can't remember how many years ago, but it's been a while.
Yep.
Yeah. So when Foundayo came along, I was just excited to try it and see if it would be a good way to kind of transition off the injectables.
So there's a lot of stuff swirling around the internet and through my patient population around that exact thing. So people are like, okay, great. I lost some weight, maybe goal, maybe close to goal, maybe even over. I've lost weight on the GLP-1s, whether it's tirzepatide or semaglutide, whether it's brand name or in some cases compounded. Yes. I've lost the weight. Now what? Yes. Am I on this for the rest of my life? Because it doesn't matter what it is, whether it's been cholesterol medications for many years. People don't like to hear that they're on something for the rest of their life. Understandable. Yeah. So the idea of a transition is being explored, going from the injectables, which people don't like as much, mostly because of, two reasons: needles and cost.
And also carrying it. I mean, like if you're traveling and this, you have to make sure it's like temperature controlled, so it's a little harder to travel with it.
So all things convenience don't necessarily add up as much in the injectables. So they're dramatic. It's great. You don't have to remember every day. Compliance maybe is good. But now you need an oral. So the oral versions that came out are really twofold. So there's the oral semaglutide, which is basically the same thing as Ozempic or Wegovy. It's just bioabsorbed and it absorbs pretty well.
If you give it time.
Right.
Yeah, that's the whole thing with it, is that you do have to give it time.
The holdup with the semaglutide oral is you have to take it like in the morning, has to be in and around some water and a certain amount of water. So there's some there's some timing issues. And then there's the Foundayo, which no one can say their name.
No, they're the actual name,
yes. But the Foundayo version, which is a new GLP-1, which we really don't have in an injectable form exactly, so it's not 100% sure how people are going to react to it. And but there is no issue around timing, right? No. You can take it whenever. It's not a certain amount of water. It just seems to be you can take it and it's at least equally as effective, right?
It's because it's a molecule and it's no longer a peptide.
Right, because it's bigger amino acid chains. It's bigger.
No, it's actually smaller than the.
Oh, is it smaller?
Because it's not a peptide chain. It's just a small molecule. So that's why the absorption is so different.
It's completely different molecule.
Yes.
This molecule is not a peptide,
nope,
which is a small chain of amino acids.
Yes.
It's a different structure.
Yes.
And it is seemingly working in the same way as I think it's the maintain studies that showed specifically that it works, really well, maybe even in transition from injectable to non-injectable. You decided to take the Foundayo and not the more studied semaglutide oral form. So why was that? Let's start with
just because I did try the oral semaglutide previously years ago, and it did not work for me. So,
but not oral, not in the form that it is today.
No.
Okay. So you didn't like it then, therefore you're like, listen, maybe I'm going to try something different. But the Rybelsus or the different forms that were there before are now...
They're different because they were able to attach something else to the peptide that is supposed to help with absorption. So that is the Wegovy pill.
Right. So the Wegovy pill, let's just call it right now, seems to be really successful. And the side effect profile is pretty low.
Yeah, pretty much the same as semaglutide, just the injectable.
Right. Maybe even, I know that it was, the side effect profile thought to be maybe even lower than the Fundio, but arguably very similar.
Yeah.
So pretty well tolerated. You can take it, not take it, and then you get into this other thing called microdosing, which is an unknown pharmacokinetic. Like, we just don't know what that necessarily means, but mentally people are like the idea of like a little somehow is better than.
Well, for some people, when they take that, like the bigger dose of tirzepatide, they seem to get like the side effects. But when they split that dose, so let's just say they're on 10 milligrams. So instead of taking the 10 milligrams all at once, they take 5 milligrams and then in a couple of days take another 5.
At the cost of maybe not getting some of the benefits.
We don't know. Yes.
Right. Maybe the weight loss, maybe the long-term cognition, even cancer reduction, which recently came out, which is magnificent. It's funny, when we first were giving these GLP-1s as a class, there was this concern of like, pancreatic cancer, is this something that could be
thyroid cancer?
It seems to be the opposite. It seems to be there's real data now to suggest that even people that have diagnosed cancer, particularly those that have obesity worsening their cancer, do better.
Yes, on the medications.
On the medications.
Yeah.
So not only is it not showing a real bump in cancer now that it's being used by millions of people, it seems to reduce the cancer ill effects, if you will, or people are not getting to the later stages of cancer that are on the GLP-1s. So it's these crazy side effects, not side effects, these crazy things that happen unexpectedly once we start putting things out in a population. Sometimes it's negative, a thing gets to be stopped, but in this case, it's more positive, which explains this phenomenon that makes it some of the more prescribed drugs in the world.
And that's why they're moving on to making more types of them. So like going on to retatrutide, and we'll see how that works.
Well, that's an exciting one. We have a research division here, and we are very hopeful to be involved in some of that investigational stuff in the past. So I may not be able to talk about that as easily in some of our future podcasts, but it's so exciting because Retta is like the name that the gym bros are using right now, using experimental versions that are probably for non-human use and taking it for whatever reason versus controlled studies that are going to show hopefully lots of benefit. But let's not go on that tangent just yet. We're talking about orals.
Yes.
Oral GLP-1s. And we're talking about transitioning from having lost the weight with the known injectable pharmacokinetics to now an oral pharmacokinetics. Keep saying it's a big word that really means like this is the amount of medication that seems to work well in human bodies.
Yes.
So we have this ability to start with a starting dose. Now, you started with a starting dose. What were your numbers and where are you going to go with it?
So I did start with the initial dose that they recommend, but it seems like it's just especially transitioning. I think like I'm already kind of like my body's used to a GLP-1, so I don't think I needed to start there and stay there for the full month. So I've been kind of escalating it a little quicker than is recommended. But again, I'm doing this as an experiment on myself.
Right. Nothing better as a doctor. I know the few times that I've been able to experiment on an early release of FDA-approved drugs, the better of a doctor I was for patients. So it's great that you're doing that, but it's even better that you're going to find the right dose that's right for you. And that everybody really needs to do this with some sort of medical supervision because this idea of like microdosing and taking things without any kind of physician supervision.
Yeah, no, it's definitely recommended that you work with somebody who knows what they're doing so that you if there are any side effects or anything, you catch it early and not waiting until, something happens.
So you're on your Fundio after having lost your weight on
tirzepatide.
The tirzepatide molecule, the peptide. So there's a little bit of a transition because it's not the same, but it's the same GLP that's being attacked. And therefore, we would expect that you will be able to maintain, because you're going for maintenance.
Yes.
Right? Which is really kind of the thing, because a lot of the studies on the orals, on the oral GLP-1s, is related to weight loss.
Yes.
But the bigger idea, I think, is like get everybody to lose the weight with the injectables, at least for now, because we know
they work better.
And then, and people like that idea. They like the idea of, okay, I'm going to be on this, then I'm going to go on this, and then I'm back to my, birth weight, or whatever, my natural, perfect weight, and everything. There's something right in the world when we kind of fix ourselves. So the truth might be that you will need the oral GLP-1s for a very long time. There may even be a situation where you need the oral GLP-1s till maybe that doesn't work. You have to go back on the injectables. Yes. We're not sure about any of this.
Exactly.
But I've already seen some patients that went from an injectable for a relatively short period of time, meaning under a year, onto the orals, now weaning off after significant lifestyle changes.
Yes.
For me, I was on, I didn't tolerate Ozempic. I tolerated Mounjaro, and I did really well on that tirzepatide molecule. And I think that over time I could use a little help in maintenance. So far, right on the cusp of maybe having gained a couple of pounds.
So maybe you want to join my experiment.
I do. I'm just trying to figure out, do I do Fundio or do I do the Wegovy pill?
Yeah.
And
maybe you should try that. I'll try this one.
Pill and we'll see how it is. Yeah.
Exactly.
Well, I think that's a great idea. We'll talk about it in the next couple of podcasts. Give ourselves 4 to 6 weeks or something and see what happens. Good idea. So anyways, just to summarize, so there's the Wegovy pill, there's Fundio. They're two different molecules. They both work pretty well. They need to be individualized. And they can be primary. People can go directly on it if they never want an injectable, but it's not as powerful.
Yes. They've done a study comparing injectable semaglutide to the orals, and the difference wasn't that much. The difference is more between tirzepatide, but again, tirzepatide's a GLP-1 and GIP, so that's why it worked better than the oral GLP-1s.
And, everyone should know that the recent data is very clear that GLP-1s are not just good they're well beyond the weight loss. It seems to be profound, maybe anti-inflammatory effects. It seems to be really good. There seems to be improved cognition, improved, response to cancer treatment at the very least, if not prevention of other diseases that are out there. Yeah. So we really haven't found a major flare-up of something that would say for us not to be recommending it, but you and I have learned so much that you absolutely need to go to a doctor that has had experience with it, because they could have read whatever they wanted. It could have be a principal investigator on some of these studies, but until you have the experience with a few hundred, if not a few thousand of your own patients,
it's different.
And get your dosing right. This, it's an interesting thing, talking about like the doctor's lounge. I'll never forget. I had a real good conversation at doctor's lounge once about statins. And the debate was in those days like, well, I want to start a statin, but I don't want to go to the main dose. I think maybe it was Lipitor.
Okay.
So I want to do Lipitor 40 and not the 80 that was particularly studied, or I want to do 20 and not the 40. And there was this idea in my brain of like, well, let's start slow and work our way up. Except that the side effect profile didn't care which dose you were at. You were going to get the side effects almost no matter what. But the potency, the effect that we were trying to give this to people so to reduce heart attacks and strokes, atherosclerosis, lipid levels, to reduce all those things, the lower dose was much, much worse. So you really weren't doing anybody a service. You were giving them less potency with an equal amount of side effects. Now, I don't know that that's the case with GLP-1s, but it's just something to keep in mind because when we do these studies, we do them in usually blinded ways around different doses. And that's how we come up with what's the human dose.
Yeah.
What's the right typical human dose. Everybody's a little bit different. That's why we all have individual doctors and we don't like go to some sort of central doctor. We have an individual doctor that individualizes us, and which is why your practice is so great because it's really individualized, precision, functional medicine, and you kind of have to wrap all that together.
Yes.
So that's, I think, a good summary of where we are as of, June 2026 regarding understanding, the oral GLP-1s, particularly as it pertains to the transition from the injectables.